just to touch about my background. I received training in epidemiology at Emory University and the American Cancer Society in Atlanta, Georgia. And then I had training in urologic surgery at the University of Minnesota in Minneapolis. And then I did training in urologic oncology and cancer genetics at Memorial Sloan Kettering Cancer Center in New York. What we are going to try to do tonight is not to lecture about prostate cancer. We're just going to talk about it. So let's consider this a chance for you guys to ask us questions and for us to answer all those questions. It's not going to be very scientific. It's just to give you an idea about what's going on in the field of active surveillance for prostate cancer and about what MRI does for such patients. So if you don't ask questions, if you don't get involved, the goal of this event is not going to be satisfied. So at any point in time, just stop me, raise your hand if there is a point that you don't understand or if you have a question that you want me to answer. Okay, so let's start by a very simple question, which is, what is cancer? And I think that if you understand what cancer is, then you would be able to understand why we treat prostate cancer, why we treat any type of cancer. So what happens with cancer is, whatever your exposure is, whether your exposure is smoking, whether your exposure is some sort of pesticide in your environment, whether your exposure is any type of chemical, what happens is that that exposure that's going to cause cancer, that exposure is continuously destroying the mechanisms that control the normal function and the structure of the cell, okay? And at some point in time, that cell is no longer looking at all like the normal tissue. And that's, if you read about it, and sometimes we talk about it, in scientific terms, that's called loss of differentiation. So the cancer cell does not have any differentiation. Within that, what also happens is that all of the cells in our body, they have special structures that connects them together, that keeps them in an organ. Because what keeps the cells inside the liver in that structure? Those molecules on the surface, when the cell loses its differentiation, when it's no longer looking like a normal cell, those structures are also no longer there. So the cancer cells are free. They can just go wherever they want. Whether they go within the abdominal cavity, if it's like liver cancer, it just falls off the surface of the liver and starts going everywhere else. Or it could go through the blood and then spread to other organs of the body, and that's what we call metastasis, okay? Not only that the cancer cells lose differentiation and they can metastasize, but also because you can no longer basically control their growth and proliferation, those cells, they can grow forever. So what happens if you take those cancer cells and you grow them on a culture, they just keep on multiplying and multiplying and multiplying. And that's why when somebody develops a tumor that is cancerous, that tumor just keeps on growing. That tumor is not going to stop growing. And that's why, for example, if you have metastasis, so spread of, let's say, prostate cancer to the bone, you develop bone pain because that tumor is just getting bigger and just compresses the rest of the structures around it and then eventually fractures the bone or pushes on the blood vessels or push on the nerves. And that's why people develop complications of the spread of the disease of what we call metastasis. Okay, so that's all about cancer. So what is the prostate? So if you look at the prostate, it's this gland that sits under the bladder. So it's right here. This is basically your bladder. And the prostate is sitting right here, okay? The function of the prostate is to produce some of the liquid that helps in reproduction. Produces about 20% of the liquid that comes out during ejaculation, okay? When we're done with the process of reproduction, the prostate does not have any other functions. The problem with the location of the prostate, if you look at it there, is that it's very central in your pelvis, okay? So it sits just under the bladder. The urine passage goes directly through the prostate, and that's why when people have problems with their prostate, when they have prostate cancer and the prostate has to be removed, people develop urinary incontinence because the pressure around the urine passage that keeps the urine inside the bladder is no longer there. And people start developing they start using the muscles of their pelvis to keep the urine inside. So that's one problem with it. The other problem with it, with the location of the prostate, so again, it doesn't have any function after you're done with your reproduction, but the nerves that supply the tissue of the penis, the nerves that are responsible for erection, they just go by the prostate. They are basically going just by the prostate. There is no separation between those nerves and the prostate. And that's also why when we do surgery to remove the prostate, those nerves get affected and people develop problems with their erections, okay? So it's not because the prostate itself is responsible for the for the continence, and it's not because the prostate is responsible for erections. It's just because of its location, just because of the important organs that are around or through the prostate, that when somebody gets a prostate surgery done, they develop these complications that people talk about of urinary incontinence and sexual dysfunction. So just to close the loop, patients who have prostate cancer are those patients who are, because of environmental exposure, because of genetics, because of age, they develop this de-differentiation of the cells. The cells are no longer looking like normal prostate cells, and those cells can go anywhere inside their body. Prostate cancer is very common. This is the most common cancer in men, and it's also a very common cause of death. It's the second most common cause of cancer deaths in the United States. And the reason that people die because of prostate cancer is that when the disease is aggressive enough and the cells are no longer in the prostate, they go to different organs, we don't have any treatment for it. We have chemotherapy, we have hormonal therapy, we have multiple lines of hormonal therapy. But if you look at how much we can prolong those patients' survival, it's counted in months. So all of the therapies that we have can prolong a patient whose disease is already outside the prostate by an average of about 4 months. So if somebody has prostate cancer that's aggressive, the best chance at curing the disease is treating the disease when it's still inside the prostate. What are the risk factors for developing prostate cancer? The first risk factor is age. And it's not because you grow older, you are developing prostate cancer. It's just because your exposure to your environment is much longer than somebody else who's like 40 years of age. Your body had much longer exposure to, whether it's smoking, whether it's environmental pesticide. It's not age, it's just the exposure. It's just a longer period of exposure. Race, African Americans have a much higher chance or much higher risk of developing prostate cancer. The disease is completely different, and we think it's genetic. Their genes are different from Caucasians, and therefore their risk of developing prostate cancer is much higher. And then family history. When we say family history of prostate cancer, it's not that you have a brother or a father who developed the disease at the age of 70, because prostate cancer is very common. So he could have developed that prostate cancer just by the factor of being old and being exposed to all of those environmental exposures for a long period of time. Family history of prostate cancer is significant when you have a brother or a father who developed the disease before the age of 55. So it has to be somebody in your family who developed the disease at a very early age. Otherwise, it's not family history of prostate cancer. If you have prostate cancer, what do you expect as far as how is the disease going to affect your body? Usually nothing. As long as the disease is inside the prostate, people usually don't see anything. There is no blood in the urine. They don't have any problems. That's in more than 90% of the patients. The way they would feel prostate cancer is only after prostate cancer has metastasized, went to different organs, and it's either causing them bone pain or causing them problems with their spines, problem with their chest, problem with their liver. Usually inside the prostate, you don't feel anything, okay? In a very small group of patients, and again, just because of where the prostate is, people do have some problem with urination, and that's very, very rare. Also because they develop metastasis to the bone, they might feel the stiffness in their lower back, hips, or upper thighs. Probably in the past 20 years, the way to diagnose prostate cancer was through doing PSA. So back in the late 80s, scientists found that if you check PSA, which is a protein that I'll talk about in a second, if you check PSA, you can detect prostate cancer early. And the goal behind all of that was so that you can't catch prostate cancer while it's still inside the prostate and treat it, because if prostate cancer is outside the prostate, there is no cure for the disease. So the goal behind screening, checking PSA, and doing all of this workup is so that you can catch prostate cancer early. So what is PSA? So PSA is a protein that is inside the secretions of the prostate. So this is basically the wall of the prostate. This is the inside of the prostate. This is the outside of the prostate, and that's where the blood vessels are. If you have a normal prostate, which is the upper picture, all of that PSA is still contained within the prostate. It doesn't get into the blood, or it gets into the blood in very, very low concentrations. But if you have any problems with the prostate, like in case of cancer, that barrier between the inside of the prostate and the blood vessels is no longer functioning as a normal barrier. And that's why the PSA starts moving from the inside of the prostate into the blood vessels. And that's why PSA becomes detectable. And that's why they say this patient has an elevated PSA, because his PSA is above the normal level that's expected from somebody who has a normal prostate that doesn't have any problems with it. What happens if somebody has an elevated PSA? So a PSA that's above the normal level, above the PSA that's expected from somebody with a normal prostate. How we diagnose prostate cancer? Unfortunately, so far, the only way to definitely diagnose prostate cancer with no doubt is to do prostate biopsy. And the way we do that prostate biopsy is, remember where the prostate sits. It sits at the base of the bladder. The bladder is above it, and this is the rectum. And what we do is use this probe. This is an ultrasound probe that shows us where the prostate is. And through that probe, we have a channel through which a needle can come out and take a piece of the abnormal tissue. And that's what's called prostate biopsy. Prostate biopsy, it's a clinical procedure. It takes about 10 to 15 minutes to be finished. The two most common complications of prostate biopsies are, one, infections. And that's why any patient who gets a prostate biopsy done usually gets antibiotics around the time of the procedure. Whether he has an infection or not, he gets the antibiotics to prevent the infection. And then the other problem with the biopsy is bleeding. So you would see blood in the urine, blood in the ejaculation, and blood in the stool. And blood in the stool because we are doing the biopsy through the wall of the rectum. Okay, so some of the bleeding gets into the stool, and that's why you see it in the stool. As far as the bleeding goes, it usually just resolves on its own. So people just drink enough fluids, it's no issue. The bigger issue is the infection, and that's why we're doing all of this. We are bringing the MRI into Springfield because we are trying to find other ways to avoid doing biopsies as much as possible. At the end of the day, though, still, in so many cases, we still need to depend on the biopsy to make a diagnosis of prostate cancer and to decide on what to do next. So, we're talking today about active surveillance. There are other therapies for prostate cancer, which are surgery and radiation therapy, but because we're trying to concentrate more on active surveillance today, I'm going to talk about that line of management. If you guys have any questions about surgery or radiation therapy, we can also talk about that when we're done with this part. But active surveillance is becoming the standard of care for patients who have a non-aggressive prostate cancer, and that's something that we can decide on. Once we take the biopsy, we look at the histology, and we can decide whether this is an aggressive prostate cancer or not, whose prostate cancer is involving a small proportion of the prostate. So if we do the biopsy, and even if the prostate cancer is not aggressive, if that cancer is high volume, is involving a lot of the prostate, those patients are not good candidates for active surveillance, and in whom prostate cancer is still confined to the prostate. Even non-aggressive prostate cancer that is even non-aggressive prostate cancer, the prostate cancer that on histology seems to be benign, seems to not to tend to spread outside the prostate. If when by imaging we can see that it's starting to extend outside the prostate, that's prostate cancer that we need to treat. If we put somebody on active surveillance, so we have this patient whose histology shows prostate cancer that is not aggressive, that's still inside the prostate, and that involves only a small part of the prostate, then those patients can go on active surveillance. And what we do with active surveillance is just we keep a very close watch on the disease, because we want to keep it in check. And if there is any indication that this disease is going to be aggressive, that it's going to spread outside the prostate, then we start talking about treatment. The way we do that is that we keep watching the patient's PSA, is that we do routine MRIs, because the MRI shows us the lesion inside the prostate, and if this lesion starts getting bigger, then we start worrying about a more aggressive type of cancer. And then in some situations, depending on how much the patient wants to stay on active surveillance, we might need to repeat the biopsy. Okay? Now, if we decide on putting a patient on active surveillance, we need to make sure that, just like I showed you on the previous slide, that this disease is low volume, that this disease is not aggressive, that this disease is still confined to the prostate. And apart from the histology, we can't get any information about the true volume of the disease, and we can't get any information about the extent of the disease inside the prostate with just doing the biopsy. The reason behind that is that the biopsy samples only 1% of your prostate. There's 99% of the prostate that's not being sampled by the biopsy that we do. That's one. And two, because of the way we do those biopsies, we can only basically sample the posterior part of the prostate. We can't sample the anterior part of the prostate. So going back to this figure, this is the prostate. This is the part of the prostate that we're biopsying. It's the posterior part of the prostate. So you're basically biopsying this posterior half. It's just this part. That anterior part of the prostate, the biopsy that's sampling only 1% of the prostate, it's not sampling that anterior part of the prostate. And in that part, about 40% of the cancers develop. And if you're African American, it's even more. So African Americans, if you have a patient who's African American, their chance of developing more aggressive disease in the anterior part of the prostate that we don't reach with our biopsy is even higher. So the risk of what we call understaging, the risk of not actually knowing what's going on inside their prostate is even higher than Caucasians. So how do we get over this? How do we get over the problem that our biopsy is just sampling small part of the prostate and that our biopsy is not catching what's going on in the anterior part of the prostate? One way of doing this, and this is the older way of doing it, is that if we decided on doing active surveillance, because we want to make sure that you don't have a more aggressive disease going on inside the prostate, we used to repeat biopsies. So the same type of biopsy that we did the first time, we just go ahead and repeat that biopsy the second time, okay? And we're hoping by doing that is that to get a better idea about what's going on in the prostate. So that was one way of doing it. The other way of doing it is that some people use special types of ultrasound. Those special types of ultrasound so far have not been proven to actually do what they are supposed to do, but the idea behind it is that that ultrasound can figure the changes in the consistency of the prostate. Because prostate cancer has more cells in it, that area where you have prostate cancer is a harder area. And that's why when we do the rectal examination, you feel hard areas in the prostate. So the ultrasound can show hard areas in the prostate. But the problem with this is that there are so many hard areas in the prostate that are not cancerous. But the ultrasound would read them as cancer and would basically push us to do a biopsy to that area when we didn't need to do that. So the better way to do this, and this is the most updated way of dealing with this, is doing prostate MRI. The prostate MRI for July of 2013 that was done in Springfield was not an actual prostate MRI that could help us decide if there is aggressive prostate cancer that we need to deal with, because it wasn't done with the specific sequences. They are called sequences, the specific images that can say, this is prostate cancer with this much certainty. So with the new sequences, and Dr. Zara will talk more about that, what we can do is when we get images of the prostate, the radiologist would look at those images and say, well, I think this is prostate cancer, and I'm probably 50%, 70%, 20% sure that this is going to be prostate cancer if you biopsy that part. And Dr. Zara is going to be talking more about that. And in order to have people who can read those MRIs and who can give us very good results that we can depend on, you need just one or two radiologists to read all the MRIs because they need to have more experience. And that's what Dr. Zara and Dr. Gleason are now doing at St. John's, because there are only two radiologists who are reading all of those MRIs. So it's their experience in reading those MRIs is probably more than anybody else in Springfield. So what happens if we find abnormal areas on MRI? This is a patient that we just did, let's see, I think last Thursday. This is a patient who had prostate biopsy on the outside. He was told that his disease is a very low-risk disease, small volume of the disease, and he wanted to go on active surveillance. So he said, okay, let's get the prostate MRI and see what's going on with your prostate. And if you have abnormal areas in your prostate, then we'll have to do biopsies to see if there is prostate cancer that we need to deal with. So it's technical, but I try to make it obvious as much as possible. If you look at this side of the prostate, you see there is this white area up top. That's the normal area. If you see this blackness there in the prostate, that's how the cancer would look like on MRI. So what we would do is take those images, go to the OR, and then biopsy. This is the line through which our needle went into that specific area that we saw on MRI. And that specific area on MRI turned out to be cancer. It turned out to be a more aggressive cancer than what the initial biopsy showed. So that's the idea behind MRI. You can see how much more details we can get with the MRI compared to the ultrasound. You basically can't see anything on that ultrasound. But the way I use that ultrasound is just to tell me which area of the prostate I'm going to biopsy, and I would be able to hit the same lesion that I saw on MRI. So but that's basically, in a nutshell, what prostate cancer is, what active surveillance is, and what we can do with MRI and active surveillance. And Dr. Zada is going to talk more about that type of imaging.